Okay, I'd like to welcome everyone to our fourth Coastal Hospice lecture, Beyond the Basics. And today I wanted to talk about palliative sedation, an important treatment modality that we use here at Coastal Hospice at the Lake. And we start with the definition. And I'm going to define palliative sedation as the intentional administration of sedating medications to induce unconsciousness but not death, to relieve refractory symptoms in an imminently dying patient. And palliative sedation is consistent with the hospice philosophy. All of you know in our boardroom at the main office, we have posted on the wall our mission and values statements, and there's copies of those here at the Lake and every place. I read them frequently to help me refocus myself, and one of the things it says is that we're not going to artificially prolong or artificially hasten the death of anyone. And certainly, as you'll see, palliative sedation, I think, fulfills those guidelines. It is a treatment that is endorsed by the National Hospice and Palliative Care Organization and the American Academy of Hospice and Palliative Medicine, and this is the physicians organization within hospice. Hospices in the United States are using this procedure routinely. And there was actually a Supreme Court case in 1997, Vacco versus Quill, which also agreed that it was an appropriate and constitutional treatment modality. Well, for fun, I thought I would tell a story. And on this urn, we see the depiction of the famous Trojan warrior Aeneas. And Aeneas is typically portrayed in full battle gear, and he's carrying his ancient father Anchises on his back as he's leaving the burning ruins of Troy. I got a ways to go in this story. I'm telling stories. I think stories are important sometimes to help us understand things. Aeneas became the leader of the remnant of Troy, and they sailed all over the Mediterranean Sea and had many great adventures. And then they eventually settled on the west coast of the Italian peninsula, and there their descendants became the Romans, at least according to legend. But while they were on these many great adventures, sailing all over the Med, they were confronted with many difficult ethical dilemmas. And Aeneas always chose the best of the choices, no matter how difficult that choice was. And his men didn't like that. They'd say, well, they would grouse and complain and say, but why don't we do thus and so instead? It would be almost as good and it would be so much easier. And the response was always the same. The response was sum pius Aeneas, I am the righteous Aeneas. And so I tell the story for a couple reasons. One, because I think Aeneas is a good representative of the hero archetype in all of our collective subconscious. But also because ethical decision-making is a big part of what we do in hospice, and it's particularly important when we're dealing with palliative sedation. And we want to make sure that we've done due diligence, and at the end of the day, when we've made a decision that we're going to sedate someone, or we've made a decision that we're not going to sedate them, we want to be able, like Aeneas, to say, sum pius Aeneas. Next. What I want to do is talk principally, therefore, about the ethics behind palliative sedation. I'll talk a little bit about the clinical aspects of it as well, but I think the ethics is the most important part of the decision-making. And the ethical framework is based on three things. First is the doctrine of double effect, and we're going to talk some more about that in a few minutes. The next important ethical framework is that we have informed consent, and the third is that we give the patient and family autonomy. And so let's take these one at a time. Next slide. The doctrine of double effect says that the nature of the act is good, and the nature of our act is to sedate the patient. That the good effect, the reason we're sedating someone is to relieve their suffering, is intentional, and there also is a bad effect, and that bad effect is loss of consciousness, and we understand that, we foresaw it, and we're going to accept that. And we're making a distinction here between the means and the effect, and we're saying that death is not the means to a good effect. And the good effect outweighs the bad effect. And so that's the doctrine of double effect. Next slide. I tried to make separate slides on informed consent and autonomy, and I got them all so confused in my mind, I decided that we really need to look at them as one whole. And so we want to make sure the patient, if they are able, and if not, their families or other surrogate decision makers, understand truthfully the nature of the facts. They have the ability to make a decision. They have the ability to choose between alternatives and can communicate their wishes. And so we want to make sure that we've accomplished all these things. We look at palliative sedation as the treatment of last resort for absolutely refractory symptoms. Now, most texts describe pain as the most common refractory symptom, although our ability to treat pain with methadone and other narcotics has now gotten so good that actually agitated delirium has become the most common. But we've had patients with intractable nausea, intractable dyspnea as well. Next. We want to make sure that we're not equating refractory and difficult. We want to really do due diligence. We want to do everything we possibly can to satisfy ourselves that we've done everything short of sedation to relieve these patients' symptoms before we move on to sedation. And we need to deal with the issue of existential suffering. Existential suffering is the patient's continued existence is what's causing their suffering. They can't bear the thought of living any longer in their body with whatever disease that they have, even though their physical symptoms are controlled. National Hospice and many other organizations have said that existential suffering is suffering and should be viewed no differently than any other kind of suffering. It should be viewed in the same light as physical suffering, and it's appropriate to consider palliative sedation to relieve existential suffering as well. What we have done in Coastal Hospice in terms of providing due diligence is that we have involved from the day we introduced this procedure about 5 years ago. We've involved the ethics committee in our decision-making process, and that all patients who are sedated are reviewed by the ethics committee, and all patients who have existential suffering, and that is the reason for the sedation, are reviewed prospectively. So that the ethics committee meets before we do that, before we do the sedation. Now, existential suffering is a component of every patient, but we're really talking about when it's the overriding component of the patient's suffering. And we've really only had one that I thought that was the overriding component. And this was a gentleman with advanced head and neck cancer whose physical symptoms were easily controlled, but he said to me, I can't stand the thought of having this tumor growing through my head any longer. And he knew about sedation because he had read about it on the internet. He says, I want you to sedate me, as he walked in the door to our unit. He says, if you don't sedate me, I'm leaving right now, and I'm going to go home, and I'm going to blow my brains out. And I absolutely believe that he meant that. And so I thought that was a good example of existential suffering. And so I got on the phone and talked to our president, and we had an emergency ethics committee meeting to deal with that case. So that's what existential suffering is. Next. Well, we need to do a checklist when we're considering sedation for a patient. We want to satisfy ourselves that the patient is in fact terminally ill. We're looking at somebody who is generally within the last few weeks of their life. We want to make sure, as we've talked about before, that their symptoms are truly refractory. We want to make sure the patient is a do not attempt to resuscitate. We want to make sure that we have achieved informed consent. And we want to discuss two options for sedation. One is respite sedation and the other is continuous sedation. Respite sedation is for a short period of time, and then we're going to turn off perhaps 24 hours. We're going to turn off the medication, and then we're going to allow the patient to wake up and reevaluate them. Continuous sedation means that everybody has decided that the patient is going to be sedated for the remainder of their lives. There haven't been large studies done, but there have been small studies looking at length of survival, and they've looked at patients in similar circumstances in which the decision was to sedate them or not to sedate them, and the survival is about the same. I think the survival on average was about 11 days in both groups. So we don't shorten someone's life by sedating them, and that is one of our ethical principles in our statement of values. So we established this mental checklist. We want to make sure that we've accomplished all these things. And actually, as the ethics committee has talked about this over the years, we've decided that we need to graduate from a mental checklist to actually a physical checklist. And so we have now a pre-palliative sedation checklist, and this is the list, and this is what we require to be done before for every patient that we're considering sedation on, and it basically goes through the list I talked about. We want good documentation of what things we have done for the patient prior to considering sedating them. And we have a timeout where we sit back, and what I like to do is I like to talk to the family, I like to talk to the staff, and make sure that everybody agrees and is on board with this. And then the physician has to sign it. We use this form in the ethics committee as well, besides being a part of the patient's record, to retrospectively review the cases to make sure that we haven't violated our own ethical principles. And so I think this has been a considerable improvement in our approach to these patients. Okay, let's back up a little bit here and talk about how we're going to do this clinically. We are only doing this at our hospice inpatient facility. We are not going to do this in people's homes. We're not going to do this in the hospital. The hospital staff is too big and there's too many nurses and staff rotating in and out that everybody's not going to be on board. If the patient is not already hardwired with an IV line, we're going to start a subcutaneous line. We're going to continue the patient's current analgesics. If they're taking oral, we're going to have to convert them to parenteral. We don't know whether a sedated patient still experiences other symptoms. Is a sedated patient still in pain but is asleep and can't tell us? So we continue those medications. The drug of choice is midazolam or Versed, which we give as a bolus, and then a continuous infusion of usual dose is 1 to 4 milligrams per hour. This is something that should not be called in. This is something that should be started with the doctor there. And 15 minutes or so after the midazolam is started, reevaluate and then titrate. We want the patient unresponsive to verbal stimuli, but responsive to tactile stimuli. So if you call out Mr. Jones's name, he doesn't respond, but you shake him and he moves around in response to your physical stimuli. That's the level of sedation that we would like. Next slide. Particularly if this goes on more than a few days, or if the patient is requiring large doses of midazolam, 15 to 20 milligrams per hour. Adding phenobarbitol is very helpful, and we particularly see this if somebody's been sedated for a few days. The midazolam dose will stay the same for 2 or 3 days, and then we'll find the dosing is starting to go up. And so this is a good time to add phenobarbitol. Usual initial dose here is 30 to 60 milligrams subcutaneously every 8 hours. And then at 30 milligram increments, we can escalate it until we get the patient comfortable. Phenobarbitol is cheap. You can use this as an initial drug to sedate people. It is not as smooth as midazolam. And if you're going to use this as the initial drug, I would probably still at least give them a bolus of midazolam to start with. It is very inexpensive, so that's a good advantage of it. The literature talks about using propofol, which is Diprivan, which is a general anesthetic agent. In really refractory cases, we have never had to do that. Propofol is difficult to titrate. It basically has the consistency of thick cream and is quite expensive. So hopefully we won't never need to use that drug. Next. Let me give you an example of a patient we had here at the lake a couple years ago. This gentleman was 77 years old. He was referred to us by the urologist. He had metastatic bladder cancer. He had recurrent small bowel obstructions. He could no longer be surgically corrected. He declined to have a nasogastric tube placed. He had horrible abdominal pain, distension, feculent emesis, despite maximal analgesics and antiemetics. I had a frank conversation with him and his family about his prognosis, that we couldn't control his symptoms by conventional means. He had been here for 2 or 3 days and we'd really tried hard, and I presented the option for sedation. The Journal of the American Medical Association has been a big advocate of hospice, and they often write hospice and palliative medicine, publish scientific papers, and the last page of every issue of JAMA is a patient page. And a couple years ago they had an issue devoted to sedation, and the patient page was about palliative sedation. So we have copies of that. Ideally, the way to do this is anticipate sedation as a possibility earlier in somebody's lake admission. Tell the family that it's a choice. We're not going to do it unless they want it. We're not going to do it unless the symptoms are truly refractory, and give them this sheet to read so they know it's a choice. I think the biggest benefit personally from the therapy of palliative sedation is the patients that don't use it, but the fact they know it's a choice, and it gives them comfort to know that the doctor has something else to do. So after we've had this conversation and they have decided they want it, I sit down and talk with the patient and family. I also talk with the staff, and I want to make sure the staff is on board with this too. If we have a nurse or an aide that's uncomfortable with the procedure, it's not going to work, because everybody has to be on the same page. We have to be a team if we're going to do this. I started the patient on, I gave him a 3 milligram bolus of Versed, and then a continuous infusion of 3 milligrams per hour, and the patient achieved the right level of sedation. They were unresponsive to verbal, but responsive to tactile stimuli. Patient slept for 5 days, peacefully and quietly passed away, and the family was very grateful. They could just see the suffering in his face that just went away as soon as the sedation was started. Challenges to this procedure. As I said, we all have, for it to work, we really all have to be on the same page. So if somebody in the loop is ambivalent, we're going to have problems with the procedure. If the intervention appears to hasten death, we give the Versed and the patient dies an hour later, they're going to think we killed them. Sometimes that's going to happen. We have to advise them we don't know how long they're going to live once they're sedated. Or the bookend to that is we're trying to get this person sedated, and they're so agitated and there's so much pain, we keep giving them bigger and bigger doses, and we still didn't get them sedated, and they died still suffering. And so the family is not happy because they thought we warranted our work, and that's something that's very important. We never want to give, we're not Midas Muffler, we don't give written warranties, we don't promise that they're going to live for 3 days after we start the sedation. We don't promise that the treatment is going to make them comfortable or make them comfortable right away. Interestingly, in terms of respite sedation, we had one gentleman who was a retired police officer, he was in his mid-40s, who had a lot of problems with chronic pain, and his pain medicines would go up and up. In about 3 or 4 months, he would go from comfortable to miserable. And we offered him a day of respite sedation. So he would actually come from home hospice, check into the lake. We would sedate him for 24 hours and turn it off, and his wife would come in and take him home. And I think we did that 4 or 5 times. He lived about a year. And he would have a dramatic relief of pain for a couple months after each respite sedation. I don't understand it. It's not scientific. But perhaps it gave him 24 hours of peace. Okay. Well, that's what palliative sedation is. It is a procedure that should always make us uncomfortable. If you think it's easy and no big deal, then there's something wrong, because it should always bother us. We should always go through that mental checklist. Have we done everything else we could? And we realize that we need to realize that it's a bad choice. I don't like to sedate people. I think it's a bad choice. I do it when all the other choices are worse. The difference between a moral decision and an ethical decision is moral decisions are easy because you're choosing between right and wrong. Ethical decisions are hard because all the choices are wrong, but you have to choose something. And so if the alternative is to let them stay awake and suffer more, and they accept it, then I think we have to move to the sedation. Question?
I come up from a background of conscious sedation.
Mm-hmm.
So if you have a patient who, say, is in CHF and they have other disease process going on that is putting them in this intractable pain, you still consider this type of sedation for them, knowing that there's a possibility it may hasten their death?
Okay. There is a distinction in medical terminology between conscious sedation and palliative sedation. Conscious sedation is a medical procedure that's done to relieve suffering when a medical procedure is being done. So you're due for your colonoscopy, and they give you some Versed for conscious sedation so that you don't experience all the gas pains from when they pump all that air in you. That is different from palliative sedation, which is done to relieve refractory symptoms for somebody at the end of life. So the terminology is very different. And the guidelines for conscious sedation, the bar is very high because this is someone we consider otherwise healthy. We are prepared to intubate this patient, put them on a ventilator, do CPR, on the outside chance that, and we have guidelines for the circumstances that it can be done. Another example of conscious sedation would be somebody needs to be on a mechanical ventilator, and we do use Diprivan in that setting. In fact, most hospitals' guidelines in the ICU is they don't allow the use of Diprivan at all unless the patient is intubated and on a ventilator. So the terminology is very different, and the goals are very different.
I think what I was asking was, if you have a patient that, if you give palliative sedation to, if they have a compromise that putting them in that state that only tactile stimulus is present, is that a contradiction to giving them palliative sedation? Or, I mean, is that a risk factor that you consider, or are you strictly going by the pain level? Are you following me?
Well, in your first part of your question too, you were asking about the risk of shortening someone's life. And the group of patients that we're dealing with, we expect very short survival. And we do have some published data with pretty fair balance of the two groups. The patients in the same setting that are sedated live about as long as the patients who are not sedated. So that we don't believe that we are shortening someone's life by offering them the sedation. Now, some people are going to pass away fairly soon after we start sedation. But best we can tell, on average, they would probably have passed away anyway. It's certainly possible that we could cause them to stop breathing from the treatment. Well, we don't give them anything, eating or drinking obviously ceases. If they have a stomach full, they could potentially aspirate. All I can say is the published data we have suggests that there doesn't appear to be any difference in survival. And I think that's important if we're going to be consistent with our own mission and value statements. And it's a very good question. Anything else?
A question. How is this different than what they practice in Europe as far as, euthanasia?
Okay. The question is, how is palliative sedation different from euthanasia? And I think that's one of the important reasons that, we have, in addition to Supreme Court case viewing this, and actually there's a second case, and I haven't gotten the citation in my slides yet. But as we talked about, palliative sedation doesn't shorten someone's life. This is somebody who's imminently dying. We expect them to live less than 2 weeks. And whether we sedate them or not, their life expectancy is going to be about the same. Euthanasia is giving medications to deliberately induce death. And in my definition of palliative sedation, I said our goal is sedation to relieve suffering, not death. So it's a very important distinction. Personally, as physicians, it's very important as well, because euthanasia is murder. And you get, in this state, you don't get the death penalty, but I mean, you could, but I mean, it's a felony, and it's a criminal charge. Even in Oregon, which has an assisted suicide law, that still is not the physician actively giving the medication. So we want to make an extremely important distinction between euthanasia and palliative sedation. Just like we talked about conscious sedation, palliative sedation, and euthanasia are three very different types of animals. And one of the concerns we had when we started doing this procedure is that we would be viewed as, a killing center. And, we absolutely are not.
So is the thing that actually that ends the person's life, what is that?
It's their underlying disease, their metastatic cancer or their end-stage chronic lung disease or whatever. People die of the disease, their hospice diagnosis.
But they're also not eating or receiving any other fluids. Was that contributing as well?
We could hydrate someone, and we have on a couple of occasions. It takes you about 6 months to starve to death. It takes several weeks to dehydrate to death. So it is pretty unlikely that either one of those factors is the cause for their death. Few published cases of morbidly obese patients who were sedated, and without eating or drinking, they lived a couple of months. Now, I don't know what all the metabolism from all that fat is, and you would think they would still have been dehydrated. But people can live a surprisingly long time. And we've had patients we didn't sedate that didn't eat or drink for weeks and weeks, and they just laid there with the music playing peacefully. So a lot of these things are beyond our comprehension.
Well, and I think adding to that, Dave, the case you talked about with the existential suffering, the piece you didn't name about that was that the decision was made to do a respite sedation. That was the ethics committee's decision, and wake that gentleman up after
24 hours.
24-hour respite sedation. And in fact, the sedation was stopped after 24 hours and he died of his own.
So he would have become unconscious in a day or two from his disease, even if we hadn't sedated him. Yes?
Can you reverse the process with Narcan?
Narcan reverses narcotics. Versed, the reason we like to use Versed or midazolam is it's an extremely short-acting benzodiazepam, and so when you stop it, it wears off pretty quickly. You have a couple hours of amnesia, but if you've ever had it, it's great stuff. I mean, it really is awesome.
You do it sub-Q versus IV.
Well, if the patient comes to us hardwired with an IV line, they got a PICC line, they've got an infuser port, we'll use it. But maintaining IV access, particularly people at the end of life and their veins aren't very good, is hard. And these drugs are extremely well absorbed subcutaneously, and so it's just easier, less suffering, rather than if the IV infiltrates, taking it out. And it's, as I said, I'm amazed. You almost think the line's IV because it works so well.
I was going to make a point when you were talking about about not eating and dehydration of everything. It's fairly well written in the literature also that it's actually many times more uncomfortable to continue to feed and hydrate people because just not going through the whole physiology, but basic. I mean, the more you put in, the more the body has to work to do something with everything we're putting in. So that actually not holding those, but you're putting more stress on the organs
Right.
of the body.
Dying patients, their organ systems are shutting down, and one of the organ systems is your gut. And putting volume or calories into a gut that's starting to shut down is just going to add to people's suffering. All right, very good questions. Thanks.